Hi everyone, it's Chastity.
And Christina.
And we recognize that during this time of COVID-19, the pandemic, as dental professionals, it's really challenging to know what is it that we should be doing in practice. We're currently advised to use our best judgment as professionals and based in research, but it is very challenging to come up with what that truly looks like when we're getting information from so many different resources.
We are here to help you, and we have created this video to help walk through all the different information that's getting thrown at us and compile it so it's much more digestible. We've taken all the recommendations and all the standards that are currently happening right now for the dental profession and compiled it for you. Hopefully, with all this information, you're going to be able to take it back to your practice and you're going to be able to implement it if you're starting to reopen.
Now, we also recognize as people skills trainers that having those conversations, especially during times of tense emotions, can be challenging. So make sure to stay tuned till the end of the video to get some tips and tricks for how you can then present these recommendations, these ideas, and what it is that you may need returning to practice to your team members.
At the Dental MVP, we use science to teach people skills to you, the dental professionals. Do not forget to subscribe to our channel so you never miss out.
So our main objectives for today, we're going to be going through engineering controls that we can use in the practice, administrative controls, PPE, and some team considerations for how we then have these conversations about what it is that we need returning into practice. We are all evidence-based providers that are listening in today, and we know that you've been doing your research, that you want to be informed while you're getting into that process of the idea of returning to practice. Now, there's going to be a lot of things that you may say to yourself throughout this presentation. You may have moments where you pause and say, I didn't know that. I never understood that. I'm already doing that. Or maybe it's something that you don't agree with. So when we have those moments, if there's something that you find that you don't agree with, we really just ask that you kind of have an open perspective to what it is that we're sharing, because there's been so many resources for where we've gained information, and it's changed so rapidly that the guidelines or what it is that is best practice is changing quickly. But then we also don't want you to get too hung up on like the one thing that is nagging at you that you really want that better understanding for, to where you're not able to take in kind of the next phase of information, because we're going to be throwing a lot at you guys today. And we want to make sure that you're able to get it all and that you're able to apply it in the way that works best for your practice. Now, the White House has created a document in conjunction with the CDC that's going to give us guidance for 3 phases of reopening America. So this outlines the gating criteria for each state or each kind of state. This can be administered based on the governor's discretion, so it might be county by county. As we look at Pennsylvania, that's how this is occurring, is it's going to be based on the area that you're in. So it depends on how many cases, how long it's been since there's been diagnosed cases, whether it's trending kind of up or down with diagnosed cases. One of the things that we want you to consider as we look at this is that in time, we're going to see cases decreasing. And that's when we're going to see a lot of things reopening and kind of getting back to a new normal. It's not going to be the same normal that we had, but that is a big consideration that we want to take in here. So if you're wanting to know where you are with the current guidelines, ADA has state mandates and recommendations in regards to COVID-19. This resource is really great. It lets you know kind of what states have been reopened for elective procedures, which states outline dentistry essential, and then where is only emergency treatment still being conducted. You can further click on each of your states to kind of identify what it is that's specific to that state. So some states, such as Pennsylvania, have updated licensing requirements, and so you're able to get more CE online during this time that we're not interacting in person. So these are all great resources just for knowing where you guys fall personally, where each state falls, and even just kind of looking into what phase you're at in general. Now, take a picture of this. We will provide it in the resources. This has been a tremendous area for us to be able to look at to see these current recommendations and guidelines and updates. OSAP has been amazing with updating these things almost immediately. So I know OSHA had a new update that came out on May 1st, and the day of, it was updated on their website. So this is a very up-to-date resource. It has a condensed list of what's available, but there are a lot more resources within this web page that kind of go on and on, including NIOSH and FDA, and really everything that you need for getting going again and looking at that process. So if we take a look at this scale, we know that we are the highest risk. Now, when we look at that, it's evaluating what is our proximity to others. So there's no way that we can really practice hygiene being outside of that 6-foot distance. And then what is our exposure risk? So because there are aerosols that are created within the dental practice, it places us at a higher risk. So what can we do to protect ourselves? If we look at the CDC's hierarchy of controls, we really want to think about this as like a filtration system. So how do we place filters in place to ensure that what is coming to us is going to be the lowest risk for exposure possible? So if we look at the top of it with elimination, that is only seeing emergency patients. So really filtering and limiting the amount of patients that are coming into the practice. Through this presentation, we're going to look more at the engineering controls, the administrative controls, and the PPE, because we want to make sure that you are prepared and knowing what it is that you can do with reducing your risk while you're in the practice and as we go back into the dental office. Once again, that's going to be a state-by-state basis. So really looking into guidelines for when is it that we're stepping out of emergency care only and then returning to elective care. But besides that, once we're getting to that point, we want to make sure that we have all of these things in place. So the hierarchy of controls has been used in dentistry before. This is not new. So we've had HIV, pandemics, influenza to SARS. And today we're going to be specifically looking at how COVID-19 is going to be affecting these hierarchy of controls and what it is that we can do specific to COVID-19. We cite a lot of resources throughout this presentation. We do just want to clarify that though we are citing ADA, CDC, FDA, anytime we're speaking in regards to OSHA, we're really talking about standards that are required. So we're talking about the bloodborne pathogen standards, PPE, and then the respiratory protection standards. And those ones are all required. So it's just a really big component as you're listening to kind of what resources we're citing to keep that in mind. So what is important for us to understand is that as we're going into practice, there is a lot of fear that spreads, and it spreads really quickly with a lot of the unknown and the uncertainty. So the best thing that we can do is just make sure that we are expanding our knowledge pertaining to what it is that we can do and how it is that we can prevent infection, because understanding things is the only time where we're able to diminish fear and allow knowledge to grow. So without further ado, we're going to dive into the research of the presentation.
Like Chastity said, with the hierarchy of controls, we want to create a filter, if you will. And so starting at the top, we're going to start with engineering controls and work our way down so that we can get a better understanding of what we can do to help reduce exposure to COVID-19. If we're not, we want to isolate people as much as possible, and then we want to reduce the risk once we get patients to the practice. So what can we do before they even get to the practice? We all know that there's pre-screening questions that are currently out there by ADA and CDC, and these are required questions that we need to be asking our patients before they even step foot into the practice. So what's really important is to make sure that we're asking them all the questions, such as, have you had a fever, a cough, shortness of breath? Have you been exposed to anyone in the past 14 days? Now, beyond that, also knowing how are you going to get this information to your patients? Have you had this discussion with your team as to how are we going to be assessing and pre-screening our patients? That way they're not already showing up at the door, we're asking those questions, and then we're going to have to turn them away and evaluate possible exposure risks. We want to be able to ask them why they're still at home. I know we have letters that are going out to some individuals, and that's great, but we also want to be contacting them before they show up for their appointment as well. So just take into consideration any like confirmation systems that you already have in the practice. Can you alter them so that maybe it says in that confirmation, please make sure you inform us if you've been, and then have your pre-screening questions right there. It's a great way to just reach out to your patients and ask these questions. A big consideration of when your patients are going through the pre-screening questions and maybe somebody says that they don't want to come into the practice is that we also have to look at opening up America, that there are vulnerable individuals. And these are people who may be immunocompromised. They may actually be caregivers of individuals who are immunocompromised. And we want to make sure that we have a plan for how do we handle the conversation with those patients. If a patient calls and says, I'm just not comfortable coming in yet, or I don't want to come in, do we have, some sort of protocol in place for how to handle those conversations? And just be aware that there are going to be those conversations that are going to happen and be prepared for them. Now, once we've gone through pre-screening our patients, then we get to that administrative control when we're working down the hierarchy of control. So what do we do next? These are really one of the most difficult things for us to implement logistically because it's just stuff that we haven't done before. I'm asking you to do things, or CDC and OSHA are asking you to do things that we haven't had to do before. So it's going to take practice and it's going to take time for us to really create a system. We want to have signs posted on the outside of the practice that, again, notifies anyone that if they have a cough, cold, fever, anything like that, that they need to notify us and not to enter the building. We also have to know what are our administrative controls when the patient arrives. Are we going out to the car? Are we having them call us and we're asking the questions over the phone? What does that look like? So making sure we have a good protocol for that and that we're screening everyone. And when we say everyone, it's not only your patients, but also screening employees. So that needs to be posted at the door, and we want to make sure that our employees are answering those questions before they also enter the building. Anyone who enters the building at that time is going to be sanitizing their hands or washing with soap and water, whatever your facility is best to accommodate. We want team members and patients to be cleaning their hands the moment that they enter the building. And then we have temperature screening that we do on everyone. Again, so this goes for our patients as well as our team members. Everyone should be getting a screening before they enter the practice. And a lot of questions come up when we go through this, which is who does the temperature screening? And there are lots of different ways to approach this. Remember that there is no right or wrong. And from us, what we're talking about is elimination as much as possible. So the more that you can do before someone enters the practice, the better. So for your employees specifically, if they can self-screen at home and then come into the practice, that's great, because then we didn't have them in the practice and have to send anyone home. For your patients, if we're going out to the vehicle and they're not entering the building, or if our patients are maybe also self-screening, if we have a thermometer that they can just hold over their head and tell you what the temperature was, but while keeping their privacy, those are options as well. Trying to figure out a good system for your practice. Everyone, in an ideal world, it would be great to have an extra floater assistant or team member that can go around and take temperatures of everybody and document it. But that might not be feasible. So you may be hearing of all these amazing options, but it just might not work for your practice. So make sure you're having that conversation with your team to ensure that we, have a system in place. We want to make sure that we're documenting our patients as well as our employees' temperatures and their answers to the questions. And what's important to note here is what conversations have been coming up around this is please treat this as if it's a medical record. We don't need this to be in everyone's viewing for everyone to see, because what's going to happen is, what if someone comes in and they do have a fever and now everyone knows about it? We have to make sure that we are protecting each other's privacy. So have a good system in place for who logs this information, whether it be the individual themselves, or you have one person who's taking temperatures and they're logging it and keeping it aside. Just have a system in place and just take that into consideration. What happens if the employee is sick? So someone calls you and they say that they have a fever, or they came into the practice and they started to feel ill and came down with a fever. CDC has some great guidelines on what to do if someone comes down with COVID-19 or comes down with any symptoms of COVID-19. But basically what we're going to do is send the individual home, clean and disinfect the surfaces, and then we're going to evaluate if anyone came into contact with them and who those employees were. Again, we want to keep it as discreet as possible because this is medical information. At that time, there's always that question of, okay, well, when can I come back to work, right? I've been sick. I've been using my PTO time, or I can only take off so many time, so much time off from the practice. When do I get to come back? And again, CDC has some good protocols for that. Typically, there's 2 ways to go about it. And this would be a good conversation to have with your practice, is handling those what ifs. There's a lot of what ifs that are going to happen right now, and it's great to act those out. So normally we say avoid what ifs, right? Just forget about the what ifs, stay positive. It's really important to have a protocol for all of the what ifs. What if the doctor is sick? Are we still coming to work the next day? How are we still operating? What does that look like? What if the hygienist is ill? How are we handling that? If the assistant is ill? Go through everyone within the practice so that we have a plan. So if it does happen, worst case scenario, we have a protocol for what that looks like. And we also have an agreement upon if we're going to do testing before we come back, or if we're just going to do the 10 to 14-day rule. Now, all of this is new and it's a lot. And how much time it's going to take, I'm sure you wish that I could tell you, okay, so tack on 10 minutes to every single appointment. I could give you an exact time. Unfortunately, it doesn't work that way. It's just going to take practice. So you do the best job that you can, make an idea of what you think it's going to take for time-wise, and just be able to adjust that. Know that it's going to take multiple times for you guys to adjust things, try again, come down with a protocol, and acknowledge that by the time you do that, it might change again. So it's really important to acknowledge that. Things to also take into consideration when it comes to time, though, is what about our patients who typically come in early? How are we going to handle those conversations? Do we ask them to wait in the car? Do we ask them to leave? What does that look like? Do we have an extra room? And can we accommodate patients if they're late? This is a conversation, personally as a hygienist, you'll want to have in advance. You don't want to be, running a super tight schedule, already, trying to learn new things. And then they say, oh, your patient's 15 minutes late and I told them that you can see them. We want to make sure that we've already had that conversation to say, we cannot or we can accommodate patients if they're late, and how much time, or is it case by case situation? Currently, in many areas, social distancing and mask wearing in public is part of the standard. If that is the case in your area, that continues into your practice. So if we are to be wearing masks in public, we are also to be wearing masks within the dental practice, and that includes all personnel as well as patients. If that's the case in your area, just remind your patients, maybe they haven't been the ones going out into public and this just might not be normal protocol for them, or they might just be thinking of your practice as clean and safe and that they don't need to wear a mask. But we want all of our patients to be wearing a mask before they come in. And in your area, that is the current guideline. So wearing a mask before you even come into the practice, and if they do not have a mask, we should be providing one for them. What's really important to remember about this is that there are some people who can't wear masks. You've got young children under the age of 2. You might have someone who's immunocompromised or has difficulties with breathing. And so be aware of what do we do with those patients. We might even have somebody who just doesn't want to wear one. Again, go through those what ifs with your team so that we have a protocol for this, how we're going to handle the situation. When they do get into the practice, we want to minimize people as much as possible in the waiting room. If you can have that 6-foot distance and you can have people wearing masks and you want to have individuals in the waiting room, that could also be your policy. If you are going to have people waiting in the car and then you bring them in, that's great too. Think about the fact of how many people usually come in with others. They might come in with their spouses or their children or friends. We want to limit that as much as possible. So having the conversation with our patients to say we're trying to limit the amount of people within our practice and within our waiting rooms. So trying not to bring guests with you would be a great policy to follow by. And then make sure that you evaluate your current waiting room and how you can accommodate people and still continue to be that 6-foot safe distance. There's things in our waiting room that we typically have that we're just going to need to remove. So any touch surfaces, any things that would be shared, such as magazines, brochures, if you have a water cooler or a coffee machine or anything like that in your waiting room, unfortunately, those luxuries have got to go. And then, of course, we're going to remove some furniture from the waiting room to create more spatial distance. The kids, we've always got some toys and something for them to play with. Some considerations to take into place is do some little take-home stuff. Get little Play-Dohs or Wiki Sticks or little crayon packets that say your office's name and some coloring pages that they can take home with them, so that if a child does come in and needs to be entertained, you have something for them. But we do want to eliminate those shared toys. Our front office team is going to go through some changes as well. And depending on the area that you're in, you may be able to, and depending on the setup of your practice, you may be able to accommodate 6-foot spacing, and you might not need to do anything other than that. You may also have a front desk team member who wants to wear a mask for their own comfort as well. So we have to have conversations with our front desk team and evaluate our current positioning within our practice to see, okay, how is this going to look? One thing that I'd like you to remember is that our front office team is the first line of communication for us. So they're the ones who smile. And even if they're wearing a mask or they're seen through plexiglass, we can still see their smile and we can see it through the eyes. So remember that your tone of voice is really important. Just because your mouth is covered up doesn't mean that people can't still hear your voice, and you can still say that you know their name and ask them how they've been and create that connection point as much as possible. If it will be allowed in your area, this is one reason why we do prefer the plexiglass versus the mask. That way they can see your full face and your full smile, and you can have a conversation without it being inhibited whatsoever. There have been studies that show that there is a loss of empathy and connection with individuals who are wearing masks because they can only see part of your face. And that's why the only reason why we're stressing that is if you can create other barriers to protect your front office team and they can still create those connection points, that's really going to create some normalcy for your patients and help connect them more to your practice and create that norm for them. Now, payment, when we're handling payments, there's going to be different options. Everyone is going to choose different things. Are you taking cash and check right now? I know when I go into a lot of stores, they're not accepting paper. They're not accepting cash. They're not accepting checks. Will you be accepting it? And if you will, how will that be handled? Are we doing credit card only? And if we're doing credit cards, am I wearing, if I'm a front office team member, am I wearing gloves and I'm swiping the card for them? Am I wiping their cards down? Am I handing the reader to the patient? There's no right or wrong here. We just want to make sure that in your protocols, you have written down what will be the appropriate protocol to take payments from patients to keep everyone safe. Communication from front to back is going to look different as well. We have a lot of PPE on, and we're going to go through the protocols of donning and doffing your PPE, which takes a lot of time. But a lot of us are not going to want to be removing our PPE to now bring our patient to the front office. And we're also not going to be able to get our patients from the reception area. We might have somebody that's running them for us. So what does that communication look like in your practice now? Take a look at some of the software systems that you may already have in your practice and might have underused for messenger systems, or find a way through some HIPAA compliant text messaging systems that you'll be able to communicate. It's just a good idea to make sure that you have communicated a way that you're going to talk to each other from front to back and so on and so forth without having to leave the operatories, because that's going to become much more difficult.
And to add into this, there may also be considerations too with pertaining to scheduling is how many patients can be seen as well during a day. So looking at your state regulations for if there's limited operations for reducing the amount of people coming into a business at a time, that's just one more kind of consideration to scheduling and time to touch on.
For anybody who still has paper charts in the practice, a lot of us love to go back to that information and be able to review the notes and everything. What are the considerations that you've taken in place to ensure that you're not going to contaminate those charts? The ADA is asking that those are not in the operatory because the operatory is contaminated. So how are you going to review charts? How are you going to do notes? What is that going to look like moving forward for your practice? Make sure that you have taken that into consideration. Paper in general is something that we are trying to eliminate as much as possible during this time. You know, anytime somebody has to hold a pen, anytime we have to touch paper, there's cross-contamination risks that are possible. But think of all the paperless considerations that are out there. There are patient portals for them to be able to pay online instead of having to handle any sort of paperwork. There's patient, all of the pre-screening questions, all of their medical history that you could send to them via paperless considerations. And we know that there's some patients that that's just not going to be an option for, but as many people as you can make those paperless considerations for, this may be a good time to think about that. And when we're talking about the front, the last thing that I always have to bring up is the kids, right? At the end of their appointment, they love to get their toys, and we've got our treasure box or whatever you have within your practice. It's a really exciting time, and we don't want to take that completely away from them. But think of some creative things that you can do, whether you already have some pre-created goodie bags that you give to children, or you have a laminated sheet of photos of all of the toys that you typically offer, and they can pick from that laminated sheet, and then you can wipe it down. Have some sort of protocol that makes sure that you don't have that, you know, big jug of, or the big chest of toys for them to dig through and be all germy with, but we still want them to have fun and get their toys too. Now, like we said, when we recap these sections, you get to take a moment, deep breathe. Hopefully that answered some questions when it comes to the beginning of an appointment, before somebody gets in there and then when they get to the practice. So did we check off some of your items on the list? Maybe we answered some of the questions that you had. Did you get to confirm anything that was already on your checklist? Well, congrats to you if you got to check that off, which is really awesome. And also, were there any moments where you might have disagreed with us? And that's okay. Make sure to write that down. It's really important to write down any moments where you disagreed so that you can come back to it and reevaluate it, and you can move forward in this presentation.
We're going to start talking aerosol control. I know that this is a big topic for a lot of us. This is one of the primary reasons that we are at such a high risk within our profession. So if we've lost you with jotting down all the things you want to consider for the front of the practice and scheduling concerns, we promise we will be recording this, and then it's going to be shared on YouTube. So you will have an accessible link that you're able to rewatch if you want to go back and touch on something, or be able to share with your team. So really kind of pay attention to this part. We're going to delve into aerosols. So remember, these are still going to fall under the administrative controls. So these are all things that we are going to have to get used to. It may not have been the typical way that we were practicing previously. And so it will feel a little bit chaotic as we get into this new process. So as we're going through some of these suggestions, you're going to have moments where you're like, oh my gosh, this just seems like such a burden to be able to do and a hard thing to figure out. Just know that you're not alone, and we're all going through these same frustrations and challenges right now. So while there's a lot to be understood about COVID-19, you know, there's a lot of discrepancy of saying, like, is it airborne or is it just generated in aerosols? The biggest thing to be aware of is that it is an aerosol that can linger in the air. And so we want to try to minimize, through administrative controls, the amount of aerosols that are being released into the room to be able to reduce risk. So if we look at the CDC's recommendations for engineering controls and workplace practices, what we really want to focus on is the fact that CDC has recommended trying to minimize any aerosol generating procedures during this time, right? And so when we think about dentistry, well, everything produces aerosols, right? So we have the ultrasonic scaling, which has been, of course, a big topic that impacts us dramatically in the provision of care, air powder polishing. But it's important to consider that even using the air water syringe is going to produce amount of aerosols that is similar to using that of an ultrasonic scaler. So there are a lot of aspects where aerosols are being generated. And a lot of our questions kind of fall down to, well, does this mean that I'm never going to be able to use the ultrasonic scaler again? Does this mean that this is just like a no-go forever, that it's back to hand scaling for the duration of my career? And we do want to reassure you that that's not something. So if we look back at the phases of reopening America again, what we're going to have to do is consider what are the risk factors. So as we see cases of COVID-19 declining over time, the risk factor for exposure is going to decline as well. And then we're going to be reintegrating a lot of these techniques that we used previously back into practice. So be assured that this very much so is more of a temporary procedure. If we look at OSHA's guidelines that were just released on May 1st, if we focus really in on that last line, you know, we'll be able to adapt this guidance to better suit evolving risk levels and necessary control measures in the workplace. So these will change over time. It's important that we keep that kind of to the back of our mind, because this is stressful thinking about how this impacts our everyday practices. So CDC recommendations are to, and OSHA bloodborne pathogen standards are to reduce the amount of aerosols that are produced during any procedures. So the way that we typically would be able to do this is through the use of rubber dams, high volume evacuation systems, and multiple other assisting devices, as well as pre-rinses. If we look at the pre-rinse, the current recommendation is that we want to use at least a 1% hydrogen peroxide. So there's some products that have this content already to them, so we would not need to do like a diluted hydrogen peroxide rinse. That's the Colgate Peroxol and the Listerine whitening mouth rinse. And we recommend doing 2 30-second rinses. So there's a lot of questions on why the recommendation for the 2 30-second rinses. And the analogy that I like to give is it's kind of like wiping your room. So if you think about that, first wipe to be to remove the bioburden, and then the second wipe is really for the disinfection of the surfaces. So 2 30-second rinses. There are some other alternatives like 0.2% povidone rinse as well. Now, I know a lot of us have routinely used a chlorhexidine pre-rinse, and it's not that chlorhexidine isn't an effective pre-rinse. So the purpose of a pre-rinse is to really reduce any type of bacterial burden that we're going to be releasing into aerosols. Chlorhexidine has been shown to do that, but for this presentation, we're really focusing on how is it that we can reduce the presence of COVID-19. So oxidization has been shown to kill this virus that is located in the saliva. But then we also want to consider that if our patient was to cough, or we have any pharyngeal excretions that are introduced into the oral cavity again, the COVID-19 is present. So the pre-rinse is effective for reducing that, but then we also want to make sure that we're taking other measures to continue to prevent that, which is why we tend to, that's why the recommendation is to reduce aerosols, because those are things that can induce coughing as well as introducing those pharyngeal secretions into the air. So during many dental procedures, the use of a rubber dam will virtually eliminate all of these risk factors. It reduces a great amount of aerosols, but as hygienists, we know that it's not really realistic to use a rubber dam while we're conducting hygiene procedures. So it's not really feasible. Another option that we can look into are some assisting devices for us that help with isolation. Now, what we want to consider is that these devices are really helpful in retraction. One of the recommendations by CDC is trying to use four-handed dentistry. Now in hygiene, we know that that's not necessarily realistic. We don't all have assistants that are going to be able to sit there with a high volume suction, so we tend to turn to these devices. They are helpful in water maintenance and retraction, but we want you to be wary about how effective they are in the reduction of aerosols. Now, one study demonstrated that there was no significant difference between aerosol reduction in a suction device compared with a saliva ejector. So there's really no substitute for using a high volume evacuation system. That's not to say that these are not beneficial devices. They may be very beneficial for you for retracting and creating some isolation while you're able to use in conjunction a high volume evacuation system. But what we want to pay attention to when we're evaluating what devices we're going to use for aerosol control is how effective they are in reducing aerosols, not particularly how effective they are in water management. All studies that evaluate the efficacy of reducing aerosols in dentistry, which it's been shown to reduce about 90 to 98% of aerosols in the air when you're using a high volume evacuation, are referring to HVE tips that have an opening of 8 millimeters or greater. And then they're also attached to an evacuation system that's going to remove a large volume of air. So this is very important for aerosol controls. So there's going to be products that are effective in aerosol management and that can be helpful to dental providers to not have an assistant. So this image compares a high volume evacuation versus a low speed kind of saliva ejector, or the mirrors that have high volume evacuation attach them as well. And those have been a really big conversation topic. The research behind these are pretty great. So when you have the attachment of these, you still have an 89.7% aerosol reduction rate. So they still have a large opening towards the top. So these are a great consideration. But as you're looking at these different assisting devices, make sure that you're looking for the research as to how much aerosols are removed with the devices. Because like I said, a lot of them are more for water management, and that's not what we're looking for during this time of practice. Another big impact with being able to reduce aerosols is going to be the operator efficacy. So I'm a hygienist. I know that in school we were not trained to use high volume evacuation while we were ultrasonicking. It was always a low speed suction device just placed towards the back of the patient's mouth. So we want to make sure as we're using this high volume evacuation that we're having the considerations for ergonomics as well as efficacy for how we use it. We want to make sure that our HVE tips always stay within 6 to 15 millimeters from the source of aerosol production. Now, there are those moments where you might be using the high volume evacuation and you notice water is building up towards the back of the mouth, so you just bring the high HVE towards the back of the mouth to collect the water. The moment we get out of that range, the device that we're using then transitions from an aerosol management device to a water management device. So that is really, really important to be considerate of, is that we just always want to be present at the working site. Now, as a hygienist, I'm sure many people are kind of freaking out as they hear this going, how am I going to hold a high volume evacuation in a mirror and use the tools that I need to use? There are options for extraoral aerosol management that really allows you to kind of free up your hands. The benefit of these devices is that they're not attached to your vacuum system, which we're going to delve into a little bit more here. So they don't create any pull on the equipment that you already have in the office, but as well, it helps to reduce the aerosols that are present in the air without having those barriers of trying to be able to hold it and maintain the appropriate working distance while doing all of the other various things that we're doing during patient treatment. One thing we really want to drive home is to make sure that we're always doing our research. So regardless of the device that you choose, there are a lot on the market. It's hard for us to do research for every single one to provide that to you. To make sure that you check with the manufacturer and look into the research. So many of these studies can be misleading and cite research from other studies. We found that a high volume attachment device might cite research of the efficacy of high volume evacuations, but not citing specific research as to how effective their specific product is. So that's really something to just keep in the back of your mind as you're looking at how will you reduce aerosols in your practice and reduce your risk, is making sure that you have good research supporting the efficacy of whatever means you choose to use. The last factor that we're going to go through in HVE efficacy is if your vacuum can really support this. This is something as a hygienist I wasn't really aware of for a long time, but when you purchase your vacuum, when the doctor purchased the vacuum, when the practice was outfitted, one of the big questions is how many users? The way that your vacuum was intended to be used versus how it's being used now is different. So before we were concerned about being able to really remove the water and that was it. Now we want to make sure that we have high efficiency to ensure that we're removing aerosols. So 90 to 98% of aerosol removal that's cited in those studies only refers to when you have a fully functioning vacuum. One of the things that you can do is always refer back to the manufacturer's instructions. So get an idea of how many operatories was this designed to support. So how many users was it designed to support? If when it was originally purchased, it was designed to support 3 users and now you have 4 operatories that are consistently running, then updating your vacuum is something that is going to need to be considered. Once again, you would reach out to your dealer that you use for your practice to be able to have this conversation or to be able to have technicians look into this to determine how it was that your office was set up. Some other considerations to take in is the distance that you are from the mechanical room. So the further you get from the vacuum, the lower pull that you're going to have in that operatory. A great way to really be able to demonstrate these, the efficacy of your suction is to do a timed water test. Now you can place a liter of water into, or do a liter of water and then place your HVE tip into the water, turn it on and see how quickly it drains. You can also do this with your low speed suction as well, your saliva ejector, to see how quickly that drains. Now the big difference is when you combine the other products that you use. So if you know when you use your typical high volume evacuation, the water drains in 10 seconds. Now plug your Isolite, if that's something that you're using, or any type of assisted suction device onto that, fill it again to the full liter and then drain it and see what the difference is in time. So that's going to give you an idea of if you're reducing efficacy in the pull by adding that device onto your suction. Another great thing to assess is how much pull do you lose when everybody is operating? Vacuums are designed to support high volume in the doctor's operatories, but it's not necessarily designed to support high volume evacuation being used in all operatories at the same time. So if you were to have each room with 1 liter of water and you turn the suction on in all rooms, you can even add it in phase. So you could do 1 room at a time, get an idea of the time that that takes, do 2 rooms, get an idea of the time, and really kind of max out the amount of operatory use that would be realistic for your practice to see how much it slows down. What you're really going to do with this information is it's going to give you an idea of how that efficacy changes, and then also to make sure you get an idea if you need to look into adding a vacuum, replacing a vacuum, or even having your vacuum serviced. With the aerosols, a lot of questions have been raised about what do you do if you have an open design then, if there's nothing that's separating the operatory rooms. It is recommended to place partitions between the operatory spaces if that's something that is possible for the practice to be able to separate patient treatment areas. So that was a newer recommendation that just came out, but something to consider. Another option would be to separate out how many operatories are being used. You may space them out to where you're keeping that good distance as well. There's some other considerations for exhaust systems. So this touches on the partitions once again. Another interesting thing that we stumbled across was having restroom fans on. So this kind of steps out of that operatory setting, but if you do have a public restroom, you could leave your exhaust fan on if it vents out of the practice.
So this came out with OSHA's guidelines on May 1st about directional airflow and partitions for those open bay units. You can check that out on that for different types of ventilation, industrial hygienists that you can hire to have them check out your practice. We're not going to go into detail about what you can specifically do because there's not enough research and everyone's practice and layout is a little bit different.
Yep, and then the last consideration with aerosol management is HEPA filters. These are a very big topic within the practice. A few big key takeaways is that you want to make sure that the HEPA filter has an H13 or higher rating. That's going to be able to demonstrate that it effectively removes coronavirus, and then a CADR score of over 240. That's going to let you know how fast it is that it cleans a room. On average, most of them are going to take 30 minutes to 2 hours to completely cover an entire room, and then you still have the consideration of the air settling for when you're disinfecting your room. So just something to kind of keep into mind if you're alternating the operatories, if that seems like it's something that would be an effective way for managing aerosols in your practice. Okay, so we went over a lot in that section. Pre-rinses, rubber dams, high volume evacuation, protocols for open bays. So please share with us if there's any questions that you guys have so far, put them in the Q&A section. If there's any big aha moments where you didn't realize that, please feel free to share those as well.
The moment we've all been waiting for.
All of the moments.
I know, all the moments. The moments we've all been waiting for. The personal protective equipment. Now, what we've done is we've gone through like a filter, right? Is we've said, okay, what can we do before a patient enters the practice, when they enter the practice? How can we control aerosols? Our last resort for safety for ourselves and for our patients is going to be your PPE. Now let's go through all of the current recommendations. Again, we filtered through this and we're giving you evidence-based information and what sort of standards are out there that we need to abide by. Now, is this what we're going to look like when we go back to the practice? I know a lot of you are kind of like rolling your eyes and laughing, and some of you might be saying, yes, that's exactly what we should be looking like. What's really important is to acknowledge the fact that everyone is going to have a different picture in their mind of what we should look like when we go back to the practice. We've all got different recommendations that we've been hearing about. And so hopefully with this next section, we're going to give you some clarity that everyone is creating a little bit more of the same picture of what it's going to look like when we go back to the practice. We've had to take these considerations into effect before when it comes to PPE and OSHA. Those protocols have been there. And in 1989 with HIV, that's when you had the massive change to PPE. And so there's not a lot of changes, more than only respiratory is really the biggest change. So some of this might be review, but we're gonna go over all of the PPE that we should be using as dental professionals to protect ourselves as well as our patients. This is the current OSHA standard that was released on May 1st. Now, OSHA standards are to protect the employees. Let's remind you of that. So it's not to protect your patients or the employer. This is to protect employees. And what they're saying in this is that unless it is a well patient and we are not doing an aerosol procedure, then an N95 is the face mask that we should be wearing. So we're going to go through this. I just wanted you to kind of like swallow that for a moment because this was a big change. We had been hearing a lot of different things from CDC and ADA, and this came out on May 1st from OSHA, who mandates to protect your employees through the bloodborne pathogen and PPE standards. So we want to make sure that you take a picture of this so that you have it. You can also access it on their page as well. But we're going to, for each one of them, it's gloves, gown, eye protection, and N95, and that's for all of them. The only difference, like I said, is for non-aerosol procedures with a well patient. You might be wearing more of a lab coat versus a gown. You still would wear gloves, eye protection, and a surgical mask. And we'll go over the difference of the surgical masks as well. Given these considerations and given the fact that there are PPE shortages, this may be affecting your schedule and the way that we're going to schedule moving forward. So what's recommended is that we are postponing procedures and that we are making sure that the appropriate PPE is used for aerosol procedures when needed. So there's a great tool that you can use. CDC has a PPE burn rate calculator. Again, CDC has a PPE burn rate calculator that you can type in how many gowns you have, how many things of gloves and mask and N95 respirators you have within the practice so that you can calculate out possibly how many patients can I accommodate during this time safely, because we don't want to get ahead of ourselves. As we start to reopen our practices, we're going to get super excited and maybe we're getting our hygiene patients in and we're getting people who have been calling every day saying, when can I get in? And we don't want to have to cancel them because we don't have the appropriate PPE or putting anybody at risk because of that. So take into consideration the scheduling that you may have to do for the time being. And again, remember that this is temporary. It's good to go over donning and doffing your PPE. Now, when we were in school, we all remember, you know, putting our gowns and our mask on, and if you accidentally touched your mask, you had to start all over. Well, we kind of haven't gone through that for a long time unless you're a newer graduate. So it's really important as a team to walk through what donning and doffing looks like and to really go through what the difference is with this as well, because things have changed. So in order, we go from gown to mask to goggles and gloves. But what's the difference here is that all of these need to be put on before you enter the operatory. And I'm going to say that again. So according to CDC and OSHA, our gown, respirator, goggles, face shield, and gloves need to be put on before you enter the operatory. Now, considering taking things off, again, practicing is great in the practice. You might just want to use a regular surgical mask while practicing so we're not overusing our N95s, but practice taking things off as well. So your gloves and your gown is going to be removed in the operatory and disposed of, but your face stays on. So your goggles, your face shield, your respirator, those items will stay on and be removed when you exit the operatory. And all of this we will have in our resource page, because I'm sure a lot of you are saying, wait, what? Where, when, what? And so you can start practicing it with your practice and your team, and start talking about it virtually or in person, depending on where you are and what you guys are doing right now. It's really important to think of, how are we going to accommodate these new procedures? Where are we going to keep things? If we have to put everything on outside of the operatory, is there a place for me to put on my gloves and put on my goggles? And is there a place for me to take them off and wipe them and disinfect them? So those are all considerations that we're going to want to take into the practice. Now, if we go through the PPE that we need to wear from head to toe, we're going to help answer some of the questions that you have about what PPE do I need to wear and why. And again, remember that this is all science-backed, so we're only going to give you the information that science supports and that there's evidence to support it. So let's start with the head. Starting with the head, there is no current direct evidence that you can pass coronavirus from your hair to your hands. There's even been studies of saying, let's pluck your hair out and sneeze on it and see if you can contract it that way. So there has been some research around this. There's not enough to say that we absolutely should be protecting our heads. That would be more of a personal choice, and it is a consideration to take because we do have aerosols that settle in our hair. So there's always disposable options as well as reusable options. It's important to try and have some consistency within your practice, or at least have an explanation. If one person chooses to wear them and everyone else in the practice does not, you know, it might just be because we have not gotten a haircut or gotten our hair dyed and we all have gray hair right now. That might be the reason why you're wearing a surgical cap. I know a lot of people, they're like, I need surgical caps because my hair is just a mess right now and we want to hide it. So there's different reasons, but make sure you have an explanation for your patients if everyone is not doing the same thing. When we take hair into consideration, think back to school as well. Is our long hair, any hair that falls, you know, above the shoulders, it needs to be put up and away. Anything that could come into contact with the direct spray or aerosol could become contaminated. So we do want to put our hair up and away. Make sure that you've addressed this in your protocols when you go back to work. Moving on to the face for our eyewear, dental health professionals do need to wear eyewear to protect them from sprays or splashes. Your personal glasses are not considered PPE, and the current recommendations right now are to wear a face shield and eyewear. So you need to wear a face shield and eyewear. It does specifically say that you can wear.
And 2 more slides. You're getting ahead of yourself.
I'm getting ahead of myself. I'm like, there are slides. I'll go over it in a second. Don't worry. So why is this? If we take a look right here, these are some protective glasses. Why are we wearing face shields? Is because if you look at those gaps below, we have a lot of gaps on the bottom and the side. And if we took those glasses off after a splash, this is what it would look like. And I don't think anybody wants their face to look like that. And so that's why face shields have been the recommendation from OSHA anytime we're going to be completing a procedure that has aerosols and splashes could occur. So this has always been the recommendation. They do want us to wear face shields to protect from any of those splashes. And that is the current guidelines right now moving forward with COVID-19. A lot of us have loops and we want to make sure that we can get some that fit over them. And I know we have been struggling to find those. Face shields are really hard to come by right now. There is not an FDA guideline currently on face shields. So if you can find something that fits over and is reusable and you can wipe it, great. You're going to need to follow the manufacturer guidelines on disinfecting. Some of them are going to be rubbing alcohol, some of them are going to be disinfectant wipes. So there's not one size fits all when it comes to face shields, other than knowing that we do need to wear them. You can wear your glasses under a face shield. Put them here. So on the OSHA website, the question was asked, can face shields protect employees instead of safety goggles or spectacles? And so OSHA did respond that face shields alone do not protect you. So you do need to wear your goggles or your spectacles underneath the face shield to protect you. Moving on, our face, this is the topic. I feel like this is the hot topic of 2020 right now. Like, this is going to be forever a conversation that we have. Remember the time when we had no masks. Remember the time when we had to learn how to wear a mask that we've never had to learn before. So hopefully we can find some humor in that as we move forward to talking about masks here. Again, I want to bring this slide back up because, as I said, the OSHA standard is to protect all the employees, and OSHA right now is saying that they want everyone to be wearing an N95 mask. Gloves, gown, eye protection, N95 mask, gloves, gown, eye protection, N95 mask. I'm just going to reiterate that over and over because OSHA does create the standards for employees, and that's what they're recommending. But if you're seeing a well patient and you don't have an aerosol procedure, and a well patient would be somebody who, passed all your pre-screening questions and doesn't have a fever, and we're not doing any aerosol generating procedures, then we would be wearing a surgical mask. And N95 masks are temporary. So as opening up America keeps continuing, you may regain the use of surgical masks sooner than some other areas. So it's important that everyone understands that we'll still be using surgical masks and that there is a difference in the types of surgical masks available to us. On your boxes, there's ASTM levels, and you want to make sure that you are getting an ASTM rated mask, because that's the only way to ensure that you actually are being protected and that your patients are being protected. And those are based off of aerosol exposures and fluid resistance are the different levels. So a level 1 is less exposure, less resistance, and then you have a level 2, which is higher. And then you have an N95, which is above that. If you were to take these 3 levels and turn them into procedures, then if you take a look at the right-hand side, take a picture of this. This will help you know where to use your level 1, 2s, and 3s. I know we're having a harder time right now getting those higher levels, so it's important to know that you still can use those level 1s. If you have a patient who's coming in who doesn't have a mask, you can give them a level 1 because they're not doing a procedure, they're just walking through the practice. So there are cases where you would still utilize this. It's important during this time too, just to address that single-use masks are still single-use. All of those surgical masks, your level 1s, 2s, and 3s are single-use. In fact, your N95 masks are also single-use. There's just some different guidelines on them right now, and we will go through those afterwards, but single-use has not changed when it comes to your surgical masks. So what is the difference between, an N95 mask, a respirator, and a surgical mask? The difference truly is the fit. So an N95 mask fits tightly around your face so that you cannot have anything seeping in. And it also is made out of different fibrous materials that helps to encapsulate and trap the virus so that it can't get either to your face or from your face to the patient. So some of them will protect you and the patient. And that's the difference of what a respirator is. There's lots of things that can change the fit, and we'll also go over those with you. So before you go and throw the computer and you're throwing your phone at me and you're saying, but I don't have any N95 masks, I just want to give you a little insider point here, is that we have spoken with the product development team at 3M, and we have been informed that there are 2 types of N95 masks that are being manufactured in bulk for dental. And some of you might have already seen some of these starting to come into your practice. These masks are like waiting and ready for you. It's just FEMA right now is in control of who gets masks and who doesn't, because they also have to make sure that the hospitals are well supplied. And until that changes, we're still going to have a shortage of N95 masks. There's a difference between an N95 respirator and a surgical N95 respirator, and I want you to be aware of that because your dental suppliers do sell both. An N95 respirator is going to protect you, but it's not going to protect your patient. So your exhale could still escape out of the N95 respirator. So that is why a face shield is really important if you're going to be wearing one of those. It also does not have a fluid resistant layer on the outside, so it needs to be protected. I will tell you that right now the FDA and the manufacturers of these masks are not recommending that you place another mask over the top of them. So you may have heard to put a level 3 over the top of it. There is no current recommendation from any of the manufacturers or from FDA on this. The recommendation is to wear a face shield to protect it from splashes and sprays. So a face shield is sufficient enough to protect the outside of our mask. And then we're only supposed to be donning and doffing it with clean gloves anyway, so that we're not contaminating it. So your surgical respirator will protect you and your patient and is fluid resistant. So that is much more ideal and something that we'll strive for in the future, if and when we can access them. If you are moving forward with using a respirator within your practice, it is very important to note that there are training requirements. And I know some of you may have heard that you don't have to do any of this training, that it's been lifted. That is not true. OSHA respirator training is still required during this time. So if you are going to start using a respirator, we do need to do a fit test, medical exam, and who does the fit test is the question then, right? Do I have to get some specialists in here? Do I have to get my OSHA trainer in here? And the truth is that anyone in the practice can do it. You're just going to assign someone. They need to be fully informed about all the different types of protocols that are out there. They need to watch videos on how to do a fit test. They need to understand why you are wearing an N95 respirator, what contraindications to use could become possible, things like facial hair or respiratory problems. That's the only thing that needs to happen in order for them to be able to perform the fit test. So designating an individual, 3M is really great, and they have some resources for you to be able to watch videos on this. And the manufacturers of all these masks usually have exactly how to do fit tests for their product specifically and protocols that you can follow in regards to that.
A big component as to why this initial testing is still mandatory is because we want to ensure, once again, that the mask is effective in its intended use. Also, there are multiple different styles of masks that will have various fits. So the first N95 that you try on might not fit your face appropriately, and you may need to explore different manufacturer options as well. And then lastly, a part that Christina touched on, but really just to kind of hit it home, a big part is also making sure that medically it's something you are able to wear. If you have respiratory conditions or something that is a barrier to being able to remove these masks, it may not be indicated for you to do that. So you want to make sure that you're talking with your healthcare provider, or that healthcare screening is a part of that initial component to make sure that it's not placing you at a greater risk to be wearing the mask.
Exactly. So when you do this fit test, what's going to happen is you're going to have the initial fit test. So what has been alleviated right now is the annual fit test. So anyone who has already been fit test for a certain make or model, if at this time you can't have access, you don't want to waste any of your N95 respirators or anything, you can skip that. But the initial test has to happen. So we do a fit testing and a medical evaluation. Now, a lot of you might be asking, okay, well, how do I do a medical evaluation right now if my doctor is not doing elective procedures? And so that's getting a little creative and reaching out to your community and seeing how they can do it. There is a medical evaluation form that you could fill out, and you could submit it to a medical professional, and they could just bring in the individuals who need to be assessed before saying, yay, okay. Or they might just say, okay, everyone's good, and then you move on to the fit test. We also have to have proper training on how to don and doff these, how to be safe with them, how to breathe through them, how to know when to dispose of them. And we have to have a written respiratory protection protocol. So these are all mandatory things to have if we are going to be implementing N95 respirators into our practice. The fit test kits that you get look like this. 3M manufactures multiple different ones. They usually have a little hood, and you spray in either like a sweet or a sour spray, and there's a whole step that you go through with moving your head to see if any of it seeps out. Like Chassie said, this is to ensure your safety. It's better to not wear an N95 mask than it would be to wear one that's not fitting appropriately, because what we're doing is then we're creating false positive, right? We think that we're protected and we're not. And we want to make sure an N95 is only effective if it fits properly. And there's going to be different makes and models that might fit you better. You might have to shave your face, guys. I'm sorry if you got a lot of facial hair, that might inhibit it, but that's again why a fit test is so imperative, to make sure it fits. Every time you put on the mask, you do a user seal check. Take a photo of this, or you can access it on CDC and NIOSH's website on how to do a seal check. This is different than a fit test. So a fit test will be anytime you change the make or model of the mask that you are using, you'll do a fit test. And anytime you don on an N95 mask, you will do a user seal check to make sure that it is still properly sealed. It's very important to know that there are a lot of fake N95 masks out there, and I'm sure people have been seeing it on the news and on Facebook about multiple fake ones. The only way to know if it is real is that it has all 6 of these markings. Not 3 out of 6 or 2 out of 6. It needs to have all of these markings. So take a picture of this. So if you have something that just says, you know, NIOSH and the numbers and that's it, that is not a real N95 mask. Another thing to note is that the N95s all go over your head. They usually don't go over your ears. So that's a big difference with them as well. So take a look at this picture, take a picture of it, and make sure that if you get your hands on N95 masks, that they are real masks. Now, because of the shortage of N95 masks, the FDA has allotted us to use KN95s, which is an N95 version from China. Now, it's very important to know that these do not meet the United States government guidelines. So these are different, but they were deemed protective enough to bring in. And there could be a lot more fakes than there are reals of these, especially because they're not monitored by our government agency. On NIOSH's website, there is a list of acceptable KN95 masks that are available, or alternatives to KN95s, as well as the manufacturers. These have been proven to be effective. We don't want you to be like the police academy over there that had, you know, masks that were KN95s and they were only filtering 20% instead of 98% of the particles. We want to make sure that you are protected. So really ensure that you're checking on who's the manufacturer of this and is it on the approved list to ensure your safety. Again, because of the shortage of N95 masks, there are also some considerations that are temporary. There has been temporary decontamination, reuse, and extended wear times of N95s. These have been approved by the FDA. If you want this information, take a picture of this, because this is where you are going to find the complete guidance on it, how to decontaminate, how to reuse them, what the extended wait times are. It is really important, though, to note that this is temporary. This is only allowed while there is shortage of masks. And same thing for the KN95s. I want to reiterate that as well. KN95s are only allowed to be worn in the United States while we have a shortage of N95s. Once we have a supply of those within our means again, then we can no longer use those. So don't bulk up on those because you might have to throw them in the trash. Same thing for your reuse and decontamination. It's important to know that each manufacturer may say something different when it comes to this decontamination reuse. Many of them are not condoning it. They're not recommending it. I can tell you for 3M, their extended use right now is 8 hours, and they are not recommending anything beyond that. And they are not recommending any decontamination because it breaks down their mass. So it's hard that these recommendations are available if you have to, if you absolutely must. However, there is not a lot of support behind the manufacturers on these right now. And for your safety, if you don't have to, then you want to dispose of them at least at the end of the day and move forward. After this reuse is lifted, again, these would be used 1 per patient. That is typical protocol for an N95 mask, would be 1 per patient.
So we're going to be diving into hand hygiene and gloves. Hand hygiene, if you're not good at it now, this is the time to get really good at it. This is, of course, one of the primary ways to be able to reduce any risk of illness and provide good infection control measurements. So taking these images as well for the proper hand washing, making sure that you have them displayed within the office next to hand washing stations as well, just to remind your patients or your team members of the appropriate protocols. Now, I know that none of us have really been able to go and get our nails done anyways, but the majority of flora on the hands is found around the nails and around the nail bed. So we want to make sure that we're keeping our fingernails short to where we're able to stay cleansable around our hands and remove any bacteria that could be accumulating there. Another consideration is your jewelry that you're wearing. So trying to remove any rings if you're comfortable with doing that, just because there's no great ways to be able to decontaminate our jewelry. So same thing, I think of that with necklaces as well. Those are things that you're wearing into the practice and can create that situation of cross-contamination. We just don't have a great way that we're able to care for our jewelry and remove any bacteria that could be accumulating on them. Big question that went around is if double gloving was necessary when you're caring for COVID-19 patients. Currently, the CDC does not recommend double gloving when providing any care to even a suspected or confirmed 2019 or a COVID-19 patient. So this is not something that we would advise that you're doing in the practice at this time. One consideration that you can make in how effective your gloves are or the quality of your gloves is looking into the pinhole testing. So pinhole testing is completed by any FDA approved glove as a part of the required testing. And it just kind of lets you know what is the likelihood that there could be a defect in the gloves. So if you aim for so surgical gloves typically have a 1.5% pinhole rate. So the lower you aim for, the less likely they are to have any defects in them. So that might be a consideration. This isn't something that you're going to find like on any box labels or anything like that. You'll definitely have to reach out to the manufacturers of the gloves to get their specific ratings to have a better understanding. It's important to know that all gloves aren't considered equal. This isn't a mandatory thing where you have to search for a certain percentage, but for that peace of mind when you're looking for what is the likelihood that your gloves could have a defect, this is something that you can default to. So we're going to delve into gowns, but gowns have been recommended for the purpose of preventing any potentially infectious fluid from contacting your clothes, your street clothes, undergarment, your skin, eyes, mouth. Like that is what PPE wants to be able to cover. So when we're talking about gowns and what surface area it should cover, a lot of people wonder, should it cover your neck? Should it cover down to your knees? The reason that we recommend that it covers these surfaces is because we want to make sure that any area that could be exposed to saliva or any potentially infectious fluids or materials are covered and protected. So if we think about the way that we sit next to our patients, as we sit next to the chairs, our knees are right towards their head. So that's why we want those gowns to be able to extend to the knee region. If we think about how far our face shields cover down to, it's typically to the chin region. So that's leaving a lot of neck exposure. So a higher clasping gown is going to create more protection and reduce the skin surface that is exposed to any potentially infectious material. So that's where that recommendation comes from. Now, all gowns are not created equally. I know I see a lot of questions that are popping up in the Q&A about gowns. So if you had a question about gowns in the Q&A that you put in, really tune into this section. There are multiple options. So we have disposable or reusable gowns. Now, we had spoke to Medicom directly, hoping that we might be able to find some information on wear times or amount of aerosol exposure so that we could help guide you kind of with what gown would be a better selection to be able to make. Unfortunately, you know, disposable gowns are intended for one use. They're not meant to be usable. They're meant to be for one patient, one use. Now, there are some different levels. So if we think about that ASTM rating that we have for our masks, there's a similar rating as well that's applied to gowns. So the same ASTM ratings. So the level 2 and the level 3, those are going to be more for the aerosol generating procedures. And then there's actually a level 4, which is really interesting. The level 4, oh, there we go. There's a nice picture of it. So the level 4 is the only one that's tested regarding viral penetration resistance. So those are the only ones that are considered by ASTM rating to be impermeable to viral penetration. Now, we also have the reusable gowns. So when we think about the reusable gowns, some big things to know about those are what are the manufacturer's instructions for use. The reusable gowns have a protective layer on them, as to many of these gowns, but it can break down over time of use. So there are typically an allotted amount of wash or dry cycles. This isn't something that we typically track in the practice as to how many times have we washed this and dried this, but keeping in consideration that it does lose that protective efficacy over time. We must change our PPE when it becomes visibly soiled and as soon as feasible if it's penetrated by any blood or potentially infectious material. So it's important to know that if our gown is soiled, even if it's a reusable, we want to make sure that we're changing out of that. We have some images as well for doffing of the gowns.
I just want to mention when it comes to reusable gowns, so gowns, isolation gowns or surgical gowns are not lab coats, okay? So lab coats and warm-up jackets, those are considered your uniform. So warm-up jackets, lab coats, those are considered your uniform. Those are not considered PPE, and it's very important to acknowledge that. So your protective equipment, when Chastity spoke about the barriers, the bloodborne pathogen says to protect you and have a barrier from blood and other potentially infectious material. That's where these fluid resistant gowns and PPE come into play. And that's what would protect you from that. And that is considered your PPE.
There are a lot of questions as to who is responsible for laundering this. What is the protocol for laundering this? In regards to the OSHA's bloodborne pathogen standard regarding laundering, there are kind of two processes that you may follow. If you are doing laundering in-house, so if you have, a washer and dryer within the facility, you want to make sure that the product is bagged at the location of use, that it's in a leak-proof, color-coded, or a labeled container, and it has that hazard sign on it. Now, if you are having a company that provides the laundering for you and they do not typically follow standard precautions, so, a company that specifically does laundry, then you want to make sure that it is in a red bag and that it's also labeled as well with the hazard sign. So for them, that's going to be a significantly more of an alert that is going to trigger them to know that there is special care for those products. Now, when they're picking that up, they are aware that you're a dental practice, so they know how to then continue on with providing the proper care for the PPE as well and the proper laundering services. But we really want to make sure that red bag alerts them that this is a biohazard.
Well, it's a red bag or a leak-proof bag that has a biohazard label.
So who is responsible for laundering? The employer is responsible for laundering PPE. So as Christina kind of touched on earlier, when we're thinking about kind of what is our uniform, which is going to be more so our scrubs versus what is our PPE, which is going to be the gowns. So it's important to know that for the gowns, that is the responsibility of the employer just to provide the maintenance and the care for that product. All PPE should be removed before you're leaving the work area. You want to make sure that you're hanging it in a designated area. A big thing for this is we really don't want to be going into the front of the practice wearing our PPE. We want to make sure that we're removing it in the areas where we're supposed to be removing it. We're not crossing into patient areas. So definitely not going to the front desk with our gowns on. Christina went through the donning and doffing of PPE as well. Like we said, this will be recorded, so if you want to even just kind of flip back and listen to that segment, you can do that later on. We're going to try to have that up this evening. Now, professional judgment should be exercised when considering the use of, gowns, foot covers, and head covers as we're moving into this. A lot of that refers to kind of what are your job-related duties. So do you have exposure, meaning that you should wear, the standard precaution PPE. When we're talking about shoes, there's no recommendations currently for using shoe covers over your shoes to prevent any kind of COVID-19 cross-contamination. There's no set recommendation regarding that. The guidelines have been to use your best judgment on whether or not you need shoe coverings. A big consideration for when those shoe coverings may be indicated is if you have shoes that maybe don't provide the ample amount of protection that you would need. So if, say, someone wears orthopedic shoes and that's the only type of shoe that they can wear, but it doesn't have any type of fluid resistance, making sure that we're putting some sort of a covering over those would be a great scenario. Or if someone typically wears like a loafer style shoe within the practice that doesn't provide the adequate coverage, that could be an opportunity to don those as well for added protection. However, when you're considering your shoe selection in the practice, really considering things that are going to provide protection. So we don't want things that are going to be penetrable by fluids or infectious materials, avoiding things that have holes in them, because we also don't want to subject ourselves for the risk of you know, any kind of punctures like that. So something that is easily wipeable and prevents from any type of sharps injuries as well.
Hey, you've taken your PPE off, right? Now we're going into infection control. So take your PPE hat off for a moment. And now we're going to go into how are we going to start ensuring that the rooms themselves stay clean for our patients and after our patients leave. What's changing? And in this section, we're going to review some of the things that nothing has changed. But it's really great to just reiterate what the protocol is going to be and what things we just want to make sure that we already have existing as protocols within our practice. If we look at barriers, complete coverage is key. So we all know the individuals who hate the saliva ejector barrier. It drives them crazy. They usually pull it off or they stop using it altogether. Now's the time to reevaluate that. There's a lot of barriers on the market, so trying different things until everybody feels confident and comfortable. Make sure that we're covering things that maybe we didn't in the past. So our x-ray tube heads, the handles, take a look at your practice and what needs to be covered. Those high touch surfaces and surfaces that have nooks and crannies that are difficult for you to clean, those are going to be the things that we want to put barriers on. Now there's a lot of products that we have within the practice that usually come with barriers. And then for some reason we stop using them. Now is the time to reevaluate that as well. All of these products do have barriers that you can put over them, your intraoral cameras, your Profi jets, your Profi ultrasonic scalers, your piezos, they all have those barriers for them. So make sure that you have the correct barriers for that. When it comes to your computer, you know, we can't go covering our computer, but maybe the button to turn it on and off, the things that we can control is what we need to control. So our keyboards. Having either wipeable keyboards. This is a photo of a wipeable keyboard from Productive Practice. There's lots of different ones out there. There's also sleeves that you can get to cover it. There's FDA approved saran wrap that you can also use to cover things and just make it really easy to cover and remove. There's your barrier tape. There's lots of different options, but make sure that you don't forget these. That is part of the ADA interim guidance that you do need to cover your keyboards and mouse. So find what works for you in your practice. In the past, when we do any of this barriering or we take things down and we're wiping, we're usually covering a 3-foot radius. That was our pre-COVID. Now moving forward, we've got 6 feet. So this might be more familiar to when we were in school and you wiped down all the cabinets and everything except for the floors between every single patient. This is what it's going to look like moving forward, is cleaning and disinfecting 6 feet. So take a look at this room. This is pretty common. A lot of our operatories look this way. If we take a look over in the corner, we always had like our clipboard, our gloves, maybe an extra box of gloves, some masks, our curing light, our wipes. Well, unfortunately, that stuff has got to go. So we got to figure out where it's going to go. So just remember that it's really important to tuck things away. You know, put the gloves away in the glove box holders, put your mask away. Make sure that you don't have mouth rinse sitting out in the sink and cups that can become contaminated. You really want to have that clean appearance and make sure that there's less surfaces for you to have to clean. There has been considerations even about removing the gloves from the operatories altogether. However, that makes it difficult if you do have a rip or a tear during the procedure. You can't leave the operatory wearing your PPE, so make sure you have a protocol for that. I just don't want anyone to get to the practice, take all their gloves out of their operatories, rip a glove, and then say, how am I supposed to go get gloves now because I have all this PPE on and I can't leave the operatory. So lots of considerations. Again, we said go through those what ifs. It's really important to make sure that you go through as many what ifs as you can and just, you know, give yourself that space to know that there's going to be changes that you might have to consistently make, but do the best you can with these recommendations. So everyone's practice is different. Put everything away as much as possible. Then it makes it so much easier when we can disinfect. One of the questions that we're getting right now is, what disinfectant should I use? And are all disinfectants created equal? And the answer truly is no. They're not all the same. They kill different viruses. They have different times. There's different aspects about them. Right now, what is recommended is to go to the EPA approved list N of disinfectants. This will give you a list of disinfectants that the EPA has said is safe for use with the coronavirus. And this will be for 2 reasons. They will have, if they have an EPA approved viral emergency viral pathogen claim, that means that it's been tested specifically on COVID-19. And we'll go through what that list looks like because there's been a lot of confusion on how to read this and how to find your disinfectant to make sure that you're safe when you go back to the practice. Now, it's very important to look at the manufacturer guidelines of your specific disinfectant because every single one of them has different kill times, kills different types of bacteria, has a different instruction for use, could be a cleaner and a disinfectant, or it may only be a disinfectant. I'll go over that a little bit more with you. And then how does it react to your dental equipment? You know, does it not do well with porous surfaces? Does it cause pitting? And that captures more bacteria. It's really important to know all these things. So let's take the most common disinfectant and go through this. And so I'm not supporting, endorsing, or anything about this product. I just want to give a product that I think the majority of dental profession knows about cavity wipes. If we were to look at this one specifically and look at its instructions for use, this is what we would come up with, is that cavity wipes is a disinfectant, not a cleaner and disinfectant. So we must first pre-clean all surfaces of debris. So if there's any splatter, blood, we need to clean it first. Then we would wipe, do our first wipe, and we need to keep wiping so that it stays wet for 2 minutes. Then we would do our second wipe, and it needs to stay wet for 3 minutes. You need to keep it wet for those full amounts of time, or else it is not killing coronavirus. That is why the instructions for use are so specific. If we are not following these guidelines, then we are not killing the bacteria. So make sure whatever product you are using, you know exactly what that IFU is, and everyone in the practice does. So if we're using cavity wipes, this could take us 4 or more wipes to maintain wetness. And it's very important to acknowledge that. If we were to go on that EPA list, like I talked about, and look it up, you will see that on the top it says human coronavirus. So it has been known to kill other coronaviruses. That is why it is on the list. If you go down to emerging viral pathogen claim, it says no, which means it has not been specifically tested on COVID-19. It has killed other coronaviruses, but it has not been specifically tested on COVID-19. And that's just something important for you to know. If we, in comparison, take a look at Optum 1, this is considered a cleaner and disinfectant. And the reason I'm using this as an example is because 1, it's only one of 2 cleaner disinfectants on the market in the dental industry. And 2, it's very hard to find if I was looking on this EPA list. So if you look under product name, it's listed as Oxy 1. I would have never looked at it that way. And that's its original product name, that's why. So what you would search by is its EPA registration number. So if you are not finding your current disinfectant on the EPA list, don't panic. Make sure you're searching by the EPA registration number. And this product specifically has a yes for emerging viral pathogen claim, which means it has been tested and kills COVID-19. Something to take into consideration, a lot of us are thinking, okay, well, I will saturate gauze so that it's super saturated, and then when I do this wiping, it will stay wet for 2 minutes because it's oversaturated. The reason why manufacturers do not recommend using gauze is not because they want you to use their wipes, but because gauze a lot of times is treated with bleach and Clorox products, and those have been known to counter-interact with the disinfectant itself. So specifically, if you're looking at Optum, it's a hydrogen peroxide base. If you mix that with bleach, it's going to mess with it. So we want to make sure that we're using the product as intended. So unless a product, a manufacturer says you can use it with gauze, make sure that you are avoiding that. Speaking of disinfecting, there's a lot more that we have to disinfect than we used to have to. So do not forget that we also have household surfaces for disinfecting. And it's really important to acknowledge who is going to be responsible for this. Now, when we're disinfecting these areas, you know, we're wanting to use a soap and water and then a disinfectant, or you can use a product like Optum 1, which is a cleaner and a disinfectant. But these are EPA registered disinfectants. Our front office team, have they or have they not been trained in the proper use of these chemicals? A lot of practices involve their front office team in those trainings, and some offices do not. So now's a great time to evaluate if I'm going to have a front office team member be involved in the house cleaning, have they been trained in these products? And if not, we do need to properly train them. Make sure that you have a routine schedule of all of these areas that you're going to take care of. Now, what else do we need to clean? And these are things that have been known, but it's good to go over because now we're thinking of, okay, we've got this virus and we're at higher risk for it. We want to make sure that everything is clean, that we're taking all the necessary precautions to protect ourselves and our patients. So when we look at saliva ejectors, there has been backflow studies that have shown that there could be oral contaminants from the previous patient that are then transferred to this patient. So between patients, whenever you use a saliva ejector, you want to clean your suction. We also want to clean our suction lines at the end of the day and after high blood producing procedures. Now, I'm not going to give you any specific recommendations on what product to use because this is going to be specific to your vacuum that you have. So you're going to need to check with the manufacturer of your vacuum on that. Now, I hope nobody is eating for this next slide. Be prepared. This is your dental unit water line. That is actually a biofilm that was pulled up from the dental line. We have a type of bacteria that is only known to grow in dental unit water lines, Streptococcus abscessus, and we want to make sure that we are cleaning and purging our water lines 2 minutes at the beginning of every day and 20 seconds between patients. And this is just, again, making sure that we're not transferring any bacteria from patient to patient. We want to keep everyone safe in our practice. CDC is recommending that you monitor these water lines. Make sure that you don't have a bacteria count of anything higher than 500 colony forming units. So you want 500 or less, and there are tests that you can do that. Some states have this required. Some of them will be quarterly, some of them are annually. You're going to need to check with your state specifically on what the requirements are for use on that. Just to touch real quick when it comes to sterilization, I want to touch on single-use items as this has been brought up by the CDC and ADA in the current time of the pandemic. They just are reiterating that single-use items are still single-use. So make sure that we treat them that way accordingly. And with that, very specifically in the ADA interim guidance, they did mention your nitrous oxide circuits. These do need to be sterilized between patients. So if you are using nitrous oxide, take a look at that. I know the companies, we've spoken to some of them, have now created little kits that you can get to make it much easier to purchase these. So how are you feeling? Are you feeling like you're ready to go back to work? Some of you are going to answer yes to that. And some of you are going to answer no. Everyone is going to have a different answer. You might have even said maybe. Maybe if I get X, Y, or Z. You know, maybe if my office does, and then you fill in the blank, right? We all have those maybes. We have our reasons that we're ready. We have our reasons that we're not. You know, in your state, in your current situation, you just may not be ready because it's not opening. But do you feel like you have everything you need to be able to reopen your practice? You have all of your questions answered, because now is a great time to make sure that you gain all that insight. It's really important to acknowledge that everyone is gaining different knowledge right now, and everyone is going to have a different answer to whether they're ready or not to come back. We want to make sure that our protocols are not creating fear or uncertainty, that everyone is working together to create these, and that we're able to have conversations, successful conversations around this topic specifically. So as science-based people skills trainers, we would like to give you some guidance on how to navigate these upcoming and current conversations that you are having regarding these protocols in the practice.
Now, many of you may have seen this quote. So we're all in the same storm, but we are not in the same boat. It's a big thing to take into consideration. So we have all experienced this on different levels. So it might be the financial constraints that we're running into, loss of childcare. We may have family members are sick that have gotten sick, immune compromised family members that we live with or that we want to be able to share moments with in the upcoming months as summer's getting here. We just want to make sure that we're really acknowledging the difficulties. So no one's experience is more important than the next person's. It's really just a time where we kind of have to calm down and accept that each person has had their challenges and there's no scale of how difficult is difficult. This has been hard for everyone. Now, we want to make sure that we're really being empathetic to our team members as we begin this process of reopening, and make sure that we're really communicating in a way that's supportive and encouraging and is helping us step together into this new normal, because it's not going to be practice as usual as we open back up. There will be changes, there will be challenges. It's going to feel more like an organized, maybe disorganized chaos. As we go back into the practice, we're going to be thinking that that's the time to talk. We really encourage you to reach out and schedule a time to talk with your team now before you're reopening. And I know that everybody listening has a pretty soon coming up opening date, but reaching out to your team members, just getting an idea of where it is that they're at. As we go back into practice with all of these administrative controls, it's going to be hectic. So we might think that there could be time with cancellations or with getting things back on track, but it will feel hectic. So if we're able to do this in advance and be as prepared as we can, it's going to help us to eliminate some of that stress that we're experiencing and some of that frustration to allow us to communicate better with our team members. As we went through this presentation, I'm sure everybody has their checklist of what their must is, like what's going to make them feel comfortable, what it is that they need to go back into practice. And we have that full checklist of what it is that we need, or maybe we're still kind of formulating it. We also want to consider that we may not have been communicating with our teams frequently throughout this process. So we might feel kind of disconnected, like the conversations haven't really happened among all of us. So we really want to be thinking about what is it that's on our checklist, but what might be on somebody else's checklist? What has somebody else been going through this process? What have our team members been experiencing? As we look at implementing our checklist or the things that we need, we really have to understand where everybody is, because our ability to implement something new or to get someone to see our view or to see someone else's view, we have to understand where they're coming from first. Right? So how are we going to do this? How do we get back on the same page with our teams, figure out how they're doing, what is it that they need to feel comfortable, and how do we move forward with that conversation?
The best way to do this is going to be with asking questions. And to be honest with you, we don't ask questions enough in our industry and just in life in general, is asking questions to understand where our team members are and where we are. I want you to all write these questions down and answer them for yourself. What do you need to feel comfortable to return to the practice right now? What things have you heard that maybe are stopping you from wanting to go back? Or what things have you heard that you feel would be great for others to hear to help them want to go back to the practice? Know your extremes. What are your absolute must and your end alls? What if somebody says, we're only doing this, and that's like your, I'm never coming back, you know, or your must is, you must provide this level of care for me in order for me to come back. You have to provide this level of PPE for me in order for me to come back. Know these answers for yourself. And also, these are great questions to have with your team. What's really important is that if you ask these questions to your team, it's going to get a little frustrating, because what's going to happen is you're going to find that they have a lot of conflicting views. There might be some great moments too where it's just aligning with you, but I can guarantee that there's going to be some conflicting views. And what happens is we all get this confirmation bias where, have you watched a webinar and someone else has watched the same webinar, and when you compared notes, for some reason, it's like one person heard something completely different than you. And that's because when we're listening to these things, we're looking and seeking to confirm the information that we already have, or the information that we've already decided is correct to us. And that's what confirmation bias is. What we want to be really careful is there's also on the flip side something called negativity bias, where, you know, if it goes against us, we're going to seek out that negativity in the conversation. So you might have this conversation with your team members about what my must are, what are your must. And if you're coming at it from a place not of openness and empathy, and you're coming at it from more of confrontational, is you're going to see the negative in everything that they have to say. So what's really great is to be able to have an open conversation, to be able to allow that dialogue to go back and forth, to be able to ask questions, to be able to respect that there will be different opinions, to be able to respect that we all have learned something different during this time, and try to learn something from each other. We don't want to ask these questions and just try to answer them for them or prove them wrong or right. We want to be able to have the conversation as much as possible. What we're saying here, okay, is we're not saying that everything is easy peasy pie, right? You can't go into your vegetable garden and say, you know, there's no weeds, there's no weeds, there's no weeds, and there's weeds everywhere, okay? What we're saying is that we have to know that there are weeds. Acknowledge the weeds, and then find a solution for them. Stay in that creative thinking side. Make sure that you're having productive conversations. And what you can do to continue to have a productive conversation is we'll give you some cues, some verbiage cues, to help you in those moments where you're just like, oh, I just want to tell them they're wrong. Or, you know, I just want to shove this fact down their throat right now. You can say instead, you could say, I'm curious about how you learned about that. Tell me more. I'm wondering. Now, these are great from an employer and an employee side. So let's take an example, okay? We just went through all of this, and you can tell from this presentation that OSHA is recommending N95 masks. So if you are going back to the practice and your employer says, we're only going to do level 3 masks, before you go shoving down a bunch of facts and everything, instead say, I'm curious about where this came about. Tell me more about how this became the protocol. I'm wondering where you gained this information from. Help me understand why we're going to be doing level 3s, because we don't know what the answer to that might be. It could be, I have tried everything to get you N95s and I can't, and this is the next best thing, and I want to protect you. So we don't know where this information is coming from, and this is just an example I'm giving you, but I want to give you an example so that you can understand how to have these productive conversations. So take a picture of these. This will help you if you're having, you know, an email or a Zoom meeting or a phone-to-phone conversation. One of the best things about working virtually right now is we get to practice these conversations. You know, we can kind of write things down, practice what it's going to look like, and we get to do scripted conversations rather than on the spot. So take advantage of that as much as possible. And we could honestly talk to you all day long about these types of conversations, the difficult conversations that we have in the practice. We could talk for hours about this, but we don't have the time for that, and that's not what today is about. So we do have a YouTube channel where this is the type of stuff we go over: how to have small talk, how to talk to difficult patients, passive aggressive coworkers, how to ask for what you want, and that will be really applicable right now, right? So there's lots of videos for you guys to watch. We do weekly videos on YouTube. It's been a little bit jumbled because of coronavirus and social distancing, but follow us on the Dental MVP on YouTube.